Assalamualaikum and good morning. Welcome to this week's edition of Breakfast at UMHealth. My name is Professor April Roslani and I'm a colorectal surgeon. And as some of you will know, March is Colorectal Cancer Awareness Month. So it is fitting that today we will be talking about a topic that is related to colorectal cancer management. Today's speaker is Dr. Mohamed Rezal Abdul Aziz, and he is a colorectal surgeon who is also the head of the colorectal unit here at University Malaya. So without further ado, I would like to welcome him to give the topic today, which is from terminal to treatable, which is regarding peritoneal metastases. The floor is yours, Dr. Rezal.
Thank you very much, Professor Dato April. Good morning, everyone. I'm Rezal Aziz. So let me share my presentation. So I was given a topic. Basically, today I'm going to talk about from terminal to treatable, why peritoneal malignancy is no longer a death sentence. This is my outline. So let's start with a case discussion to make everybody alive. So we shall see. Right, so I have 55-year-old female who presented with a painful abdominal distension secondary to large bowel obstruction. CEA which is a cancer marker, is 3.1. This CT abdomen and pelvis shows there is constricting lesions in the descending colon. So with the note of patient has abdominal pain, abdominal distension with evidence of bowel obstruction, she warrant an emergency Hartmann procedure. So intraoperatively, we found that there is a constricting tumor of the descending colon with grossly dilated small and large bowel up to the tumor, no free fluids or peritoneal nodule. So the histology came back as the adenocarcinoma, moderate to poorly differentiated, and it's a PT3N2A, which 6 out of 17 lymph nodes has been involved with lymphovascular invasion and perineural invasion. So this classified as a stage 3B after we complete the staging CT scan for this lady. So with that note, we refer this lady to oncologist, and patient has completed 12 cycles of adjuvant FOLFOX. So post-operatively, when we see her CEA level is 0.8, and then the highest is 1. And she had completion of colonoscopy, shows the proximal and also the stump has no evidence of recurrence. And also CT scan, there's no evidence of recurrence. So with that note, we reverse the stoma that she had, and intraoperatively also noted there is no peritoneal nodules or palpable liver lesions and no ascites. The pelvic organs are grossly normal. So let's see the chronology of this lady. So this is what the patient presented to us as an emergency 2018, and a year later we did a reversal of Hartmann procedure. So of course, when all the colorectal cancer patients need to come to colorectal clinic for surveillance follow-up. So as surveillance, a year later after that, hence 2 years after the index surgery, so the patient found that to have left pelvic mass, which is reported as this could be nephrotic lymph nodes. So then we look at the CEA level, and it's still normal. The CA1 to 5, and then shows that it's slightly higher but not remarkable. So because it's near the pelvic organs, and then it's there also query of is an adnese. So we refer to gynecologists, and they did the pap smear, and it's negative to intraepithelial lesions. So with that note, patient, and we are all happy that the patient is going for continue the surveillance. So what's next? So patients still continue the surveillance with us. So in March 2021, found that there is a pelvic and bilateral paracolic gutter free fluids with increased degree of left paracolic gutter with a new enhancement nodule within suspicious of peritoneal metastases. The tumor markers is still within a normal range. So then we proceed with PET-CT scan shows that there is an SITs and also active peritoneal deposits. So in that case, we can say that from 2018 to 2021, patient has confirmed may have peritoneal disease. So hence patient has metastasis, hence patient have a recurrence after, we can say, after 3 years. So patient continue to have a chemotherapy, which is capecitabine, and repeat CT scans after that. So the CT scans after that shows improving the ascitic fluids. The tumor markers is always on the normal side in these patients after the surgery. And then with that note, continue surveillance. With the continuing surveillance, we repeat the CT scan. Patient has a good response with the chemotherapy, so we continue again. So after that, in 2023, found that there is quite a significance in ascites. Patient presented with abdominal distension, and then we repeat the PET scan, found there is tumor deposits, and is also highlighted in the PET scan, and it shows that there is a peritoneal deposit. So hence we took a biopsy, and he has confirmed that this is a metastatic adenocarcinoma, and immunohistochemistry shows that it's from colony origin. So with that note, the oncologist referred to us. So what do we do? Hence, this patient need to work out. So we look at the tumor markers. So it's still on the normal side. We review again the histology. Yes, it is confirmed metastatic adenocarcinoma. And then with the immunohistochemistry shows as such. And then we did the upper and lower scope. Upper scope shows gastritis, is nothing significant. Colonoscopy shows there is no intraluminal recurrence. So hence, this patient is a metachronous descending colon adenocarcinoma with Buchenberg and peritoneal metastases. So hence, we brought out to our MDT, colorectal cancer MDT, and consensus from the oncology and from ourselves, from the radiologists and histopathologists. We're going to go ahead with CRS and HIPEX, which stands for cytoreductive surgery and also hyperthermic intraperitoneal chemotherapy. That means cytoreductive surgery to remove all cancer that we see intra-abdominally. Then after that, we give heated chemotherapy, 42 degrees Celsius for 1 hour. So with the upper and lower scopes, is nothing significant. So we have to do part of the workup is the laparoscopy PCI, we call it. So what it means is we want to know how many peritoneal deposit, how bad is the peritoneal deposit in the abdomen. So unfortunately for this lady, because she had the 2 previous abdominal surgery, we can't see on the lower abdomen, but on the upper part of the abdomen, we can there is no peritoneal disease. So when we do the laparoscopy PCI, we actually have to score this patient according to the size of the peritoneal nodules. And the maximum PCI is 39. So what is HIPEX? And so HIPEX is actually hyperthermic intraperitoneal chemotherapy. So this is what happened in the intraoperative theater when the patient has completed cytoreductive surgery. Means that to remove all cancers in the abdomen. So what we did, you can see that on the left side there is a machine. This machine is actually by Belmont. It consists of a heater, a chamber, and also pump. So the chamber is basically where we put in the chemotherapy, then it's pumped and circulate into the abdomen for an hour. So, so we need to have a minimal contact in the operating theater, where one of the trainee specialists are going to be there, and then to monitor, make sure there is no leakage at the surgical wound. So in this lady, when we did an intraperitoneal surgery, CRS and HIPAC surgery, her PCI score is 15. You can see there is a disease burden mostly on the lower part of the abdomen and also on the right subdiaphragmatic. So this is what we see. You can see that. So in that case, we have to strip all the peritoneal that involves. So the glycinectomy, and then you can see how diaphragm has been stripped. The peritoneal has been stripped from the right side diaphragmatic. The liver is actually, we can have the liver on our hand. We actually have to mobilize the liver because it goes all around posteriorly down to the inferior vena cava. So this patient had, you can say, a multivisceral surgery. After that, we continue with the CRS and IPAC. So this is the patient right ovary. You can see it's enlarged and it's multicystic, and it's actually Kuchenberg, and also the uterus and the left ovary has to be removed by the gynecologist. And the pelvic peritoneum means that we have to strip all the peritoneum in the pelvis. We have to really skeletonize the vessels and to ensure that there is no peritoneal seedings down below at the pelvis. So after that, then we put in the chemotherapy in, and after that we have to, and we open up again, and you can see how beautiful the small bowel is, nice and shine, and the abdomen is clean, so it's we call it CC0, means there's nothing that we can see is actually cancer in there or tumor in there. And the final histology shows is metastatic adenocarcinoma to the right ovary consistent with metastasis, lymphovascular invasions, and the peritoneum that we took it out and also has a malignant cell deficit. So in this case, let's look at some of the trials. So is this CRS and HIPAC is very good. So we can say that you can see from the Kaplan-Meier curve on the left side is the completion of cytoreductive surgery. That means no cancer. There may be removed all cancer tumor or tumor in the abdomen. So if we manage to remove all, the survival curve is better. So if we leave something behind, the survival curve is lower. So that's what I'm trying to say here. And then as the standardized regime from SOGI 2022, SOGI is actually Peritoneal Surface Oncology International. They have standardized that the regimen of chemotherapy, this regimen chemotherapy is from one institution, from other institutions are different, and so that they have standardized internationally. So for colorectal cancer, it's mitomycin 35 milligram per meter squared for 42 hours, and also for 42 degrees and 1 hour. So with that note, they study it and they are looking at the bidirectional therapy. Bidirectional therapy can be anything in combination with HIPAC with intravenous chemotherapy, or at the moment, they are studying about PIPAC, which is basically they put in the chemotherapy laparoscopically, aerosolized and pressurized. So but the result is not out yet, and is still at the moment is under palliative treatment rather than curative as per HIPAC. So why colorectal cancer? Because it's the third most cancer and the second leading cancer death worldwide. And 15% of this patient, we found that there is a peritoneal disease at time of diagnosis. And 10 to 20% develop metachronous peritoneal disease, which shown on this patient means that patient had an index surgery. Then after 6 months, patient developed peritoneal disease. So we can see that here on the Kaplan-Meier curve on the right side, any patient who had peritoneal metastases, their survival curve is way lower to compare to the lung and also the liver. So if patient didn't have anything, just supportive care, their lifespan is only 6 months. With systemic chemotherapy, it's only 12 months. Why is that? Because out of our the cardiac output, only 2% of cardiac output goes to peritoneum. Means that they have a very peritoneal disease, has a very poor blood supply. That's why intravenous chemotherapy not able to reach there adequately. So with the CRS and HIPAC, means that HIPAC is a direct contact of the chemotherapy, so you can increase survivals up to 40 months. So where is this patient in our AGCC staging? So they're actually down below, they're actually the last row of their life. So it is very important for us to look at the peritoneal disease, and it makes a difference of the patient overall survival. So peritoneal disease malignancy can occur from anywhere, can come from anywhere. It can also has a primary peritoneal origin, but the one that we're looking at is colorectal cancer because it gives benefits with CRS and HIPAC. So if we're looking at the traditionally, why it is a terminal disease. It paused somehow. Oh, all right. Okay, why it is? Because it's a diffuse disease pattern, and the tumor spread widely across the peritoneal surface, and it's difficult to remove completely. Mind you, for this patient, it's not bad, and some of them is actually at the foramen vinculo, lesser sac, and it's actually near the back area of the liver, and all in the danger zone, in the near the portal hepatis. All of that need to be skeletonized and removed. And as mentioned earlier on, there's a limited penetration with systemic chemotherapy because it's only 2% of cardiac output goes there, and large tumor burden. And can we remove all the tumor or not? Because it has a large tumor burden, and then lack of effective treatment options. That's why there's a lot of ongoing research on and on. Every year there's trials over trials, basically the aim is to improve patient overall survivals with peritoneal disease. So when we look at the traditionally, and there is a change in paradigm. So peritoneal disease recognized as a regional disease in selected patient. CRS and HIPAC, no CRS remove the microscopic disease. What we are trying to achieve is CC0, means no tumor that we can see. And then after we remove all the cancer intra-abdominally, then after that we give heated or hyperthermic intraperitoneal chemotherapy, and to target the microscopic residual disease that we can't see on the naked eye. And then selected patient can achieve long-term survival, multidisciplinary care, improve quality of life, because we'll ultimate all the experts in the peritoneal disease can or cannot that this patient actually improve their survival. So peritoneal disease has no longer uniformly terminal. Selected patient may benefit from curative intent local regional therapy. Now, where are we? So it's introduced by Paul Sugar-Baker. If you, all of us has opened book Bailey and Love. His name is everywhere in Bailey and Love. It talk about the peritoneal disease, and basically, he's the one who invented CRS and HIPAC in 1980s. So where are we in Southeast Asia? Right. So first is in Singapore, in 2012 is Thailand, then Philippines, after that followed by us in Malaysia. So in Malaysia, here we have to thank my moderator at the moment, which is Professor Dato April, to set up the CRS HIPAC in University Malaya, and it happened to be the first one in Malaysia in 2018. It's a colorectal-led initiative, and it's because of we have all the specialty on board, and we're collaborating with each other, and we have a good support from the institution. So we managed to publish a paper last year, which involved all the team members at that time. And then the key point here is we tried, the message is must have a strong MDTs and adequate infrastructure, and it has to be centralized service. So one need to be trained. So myself, I went to National Cancer Center Singapore because it has the bulk of peritoneal disease, and also a lot of trials going on there, and also the surgery itself in the National Cancer Center Singapore. So then I collaborate and also did another fellowship in Germany and entered school of European School of Peritoneal Surface Malignancy. So in Malaysia, who is the HIPAC surgeon? So here we are, and then the one that has is only spoonful, and they work in the different centers in Malaysia. So here, the patient can present in many colors. Okay, some does not present with abdominal distension at all. Some present with
Rezal?
Yeah.
Sorry, your slides are not moving.
Oh. Is this slide?
It is still on the slide which shows the change in paradigm.
Oh gosh.
Yeah.
Okay, something wrong. Tell you what. I'm going to stop sharing and reshare.
What we see now is the slide on peritoneal fluid. So, okay, now it's moving.
All right. Okay. I think I just change in paradigm. Okay. So you saw. Okay, you've seen this. Okay. So here we are. Where are we in Southeast Asia? So for us, we actually start our services in 2018, and I thank Professor April in actually starting up the CRS and HIPAC service in University Malaya, which happened to be the first one in Malaysia. And we managed to publish our paper, and it's what the paper says is it requires strong MDT, adequate infrastructure, and centralized services. So one need to be trained. So I've trained in NCCS and also did an adjunct fellowships in European School of Peritoneal Surface Malignancy. So here is the HIPAC surgeons, we can call it, throughout Malaysia. So there's only a spoonful, as we call it, but they are in the different centers. Now, they present, patient can present with many presentation. Not all present with abdominal distension. Some can be just like normal, like us, but they have peritoneal disease, which ascites has not developed yet. So on the middle slide there, so it's actually patient present with Sister Mary and Joseph node. So this is a different spectrum of peritoneal malignancy. When we did a laparoscopy PCI, you can see that's all the white spots there, and it's quite advanced. You can see that's liver, and then on top of that is a diaphragm. So you can see how extensive is this. So our question is, can we remove all of it to make it CC0 or no cancer that we can see in after we did the surgery? So you can see, and you can see that the bowels there, and it looks normal to us and at the naked eye, but when we flip and then assess properly, you can see there is a tumor nodules at the junction between the small bowel and also the mesentery, and the mesentery visceral peritoneum need to be stripped off, and then the mesentery actually been skeletonized in the operation. So that makes the operation long hours. You can see how extensive it is, and you can see there is a peritoneal deposit at the small bowel itself. So we can do this, we can do an enterotomy and remove this and also suture back, which is not a problem. But if it is quite extensive, more than 200 centimeter of the small bowel, then we will say, no, we're not going to do an operation on that particular patient. So that is the uterus and also the ovary. You can see how extensive the peritoneal disease is. So definitely that gynecology organ needs to be removed later. So why is this happen? So basically they call it a peritoneal fluid circulation pathway. So that is the pathway it goes. You can see where it goes up, and then it mostly goes to the right subdiaphragmatic. So that's why right subdiaphragmatic hits first, and then where the deposit normally happen there. So it can common area is a greater omentum, pelvis, right paracolic gutter, subdiaphragmatic space, and also the diaphragmatic peritoneum. So there are other modes of peritoneal metastasis. So it can be from the lymphatics via the stomata, which is channels of the lymphatics. Commonly is at the omentum and appendix epiploicae. Hematogenous rare, as I mentioned, only 2%, and then arterogenic spread. That means when we did the surgery, there is a tumor perforation, and then we can't see any seedings, and then it's actually later developed peritoneal disease. So what happened to this patient then? So post-operatively, after the CRS and HIPAC, patient had a adjuvant chemotherapy. Remember, I told you there's a bidirectional chemotherapy. So this patient has the complete the adjuvant therapy, and then the CEA level somehow on this lady is always low, and then but we're not going to buy on the tumor markers, but we have to do it as part of the surveillance. And then the surveillance CTTAB shows there is no recurrence, and this is metastasis up to now. And we actually interested to know the biology of these patients, knowing the fact that after 3 years, and then this patient developed peritoneal metastases, that shows that the biology is actually good. And then compared to a patient who had a peritoneal metastasis less than 6 months, that means it's aggressive cancer. But having said that, the reason we would encourage patients to do the tumor marker, KRAS, NRAS, BRAF, and microsatellites testing is to know later if they develop, can they actually have the benefit of targeted therapy or immunotherapy, which on the trial at the moment. So we have to always ask our question in MDT: who benefits from TRS and HIPAX? Which patient achieve cure? Where is the therapy performed? And then how does the CRS HIPAX works on certain kinds of peritoneal disease with the different primaries? But when should the CRS HIPAX be considered? So who should we consider for CRS and HIPAX? The high risk one, the one with a cucumber in this case. But the risk of peritoneal metastasis is 71%. The synchronous peritoneal metastasis, which has completely resected, the recurrence rate is also 71%. The moderate risk, the perforated tumor, and then also the T4 tumor, which is have not perforated yet, but they are about to perforate. And then the other one, we're looking at the biology risk, which is the mucinous. Now, there are other biology risks, for example, the signet cells, goblet cells, and then so there are a group of patients which does not do best. So it's not that we don't do for this patient, but we actually go case per case basis, and it depends on the MDT. All right. So next is, once this is all the landmarks as I went for the SOGI meeting internationally, represent the university, and they were talking about this, a COLORECTAL, and then profilochips and also HIPAC T4. What is all these trials is all about? So basically, they want to know how can we prevent this peritoneal disease, because it's such an extensive disease, and the survival is not great if the patient get it, and it's worse than the patient if actually young. So what they're looking at is for the COLORECTAL trials, is all these trials is, can they do this HIPAC surgery as a prophylaxis? Means that, okay, if they have a T4 tumor, can we just give chemotherapy? And then, or when the patient had, for example, for COLORECTAL trial, is actually patient had a primary surgery, and then after that, okay, it's a T4 tumor, and then it's confirmed that this patient has the adenocarcinoma from the histology. Then they go a week later to do a HIPAC. So the result shows that there is no reduction in peritoneal malignancy, and there is no disease-free survival benefits. So that is on the COLORECTAL. And then that was in 2019. And then after that, in 2020 is the fellowship, profilochip. So basically what profilochip look at plan for reoperation in a high-risk patient. And then what they do is, after the surgery, so within the 6 months, and then they did a laparoscopy surgery to see, oh, is there any deposits or not? So they found that there is no benefits, disease-free survival benefits, and there's no justification for routine second look. And for the HIPAC T4 in 2022, and is basically the research conducted in basically in Spain by Alvarado. So what they're looking at is that this 2 arms patient who has a T4 tumor from the CT scans, and then they do an immediate CRS and HIPAC on the index surgery. But they found that there is a better local regional control, but there is no benefits in overall survival or disease-free survival. So hence, prophylactic HIPAC is not a standard treatment up to now. Okay. So our take-home message is prophylaxis HIPAC strategies have consistently failed to improve survival. Timing alone does not determine benefits. That means that how fast you do your HIPAC, if you want to recur, it will recur, but it's actually the biology that we are looking at. So this is what all the research is all about. We're going to look at the biology. So peritoneal metastasis remains difficult to prevent. I think I'm at my last slide. Okay, so of all this, okay, the quick question in optimizing HIPAC for colorectal cancer, who? So it has to be in a homogeneous populations, okay? So it means that the population that I mentioned earlier, the high-risk one, okay? But we have to really look at the biology. And then also we also sometimes in our country, yes, we have an access to test for tumor biology, but not all patients can afford, because it's not actually funded. So then what we do is, with the oncology, we actually test the biology by giving chemotherapy. And then after giving chemotherapy, less than 6 months, patient occurs, means that have the peritoneal disease. Then we tell that, okay, this could be an aggressive cancer that we are dealing with. Or like this lady here, after 3 years that she developed peritoneal disease, that means, all right, this is a good kind of like biology. So which patient peritoneal metastasis outcome must be, we're looking at the free survival, and then after that, clinical meaningful endpoints that we'll discuss in MDT. So when the timing is upfront at the index surgery versus delay second look surgery. So mentioned to you already. So there is a difference. So basically, if the moment we detect the peritoneal disease, we have to be very, very, very meticulous. And then at the same time, we have to really adamant and chase all the results, and actually brought up in the MDT. And within few weeks, patient will actually have their surgery completed. where it has to be in the expert center. Expert center means what? It means like in hospital that have all the specialty, for example, in UM. And then HIPAC strategies is a standardized regimen. So we can say from the SOGI 2022, they have standardized for colorectal is a MMC, which is the mitomycin rather than oxaliplatin. And then the duration is 60 minutes. So the challenge here, so it's not just the HIPAC, so it's actually selecting the right patient at the right time and with the right strategy. So my acknowledgement is to all the department that involved in the MDT. In general surgery, there are many actually. We constantly we have support from hepatobiliary, and then also urology and vascular surgery. Gynecology, you can see that earlier on, the gynecology organ is often involved, and then we definitely involve them. Oncology, so we don't have to say, they're always involved. And then also the radiology, who actually determine, can they determine the peritoneal disease early, but not at the one that grossly that all can see from the naked eye. So we want to see the small one. Is it may be a peritoneal disease or not? Is it accessible for a radiological biopsy to confirm that this is peritoneal disease before it got worse? So this is the importance of all this MDT. So with that note, I thank you everyone and hope you enjoyed the talk.
Thank you very much, Dr. Rezal. The floor is now open for questions. And in fact, we do have a question from Prof. Victor Ho, and he wants to know if there's any age limit to patients who undergo CRS HIPAC.
Hi, okay. So yes, CRS and HIPAC involve high morbidity, which is up to 30%, but not very much in mortality if it is it has been strategized from the start. And what we're looking at is, if you talk about, is there a cut point age, then at the moment we actually don't put a cut off age. But having said that, we are actually looking at patient fitness for surgery. Means that we have to assess properly. How do we assess is, for us, is a CPAT, we call it cardiopulmonary exercise test, which consists of the echo and also the pulmonary function test, and while the patient is exercising. So if the patient is moderate risk, so can we optimize this patient to a lower risk? And then we have to talk to the sports medicine. How soon can you optimize this? Because as you know, the moment they have peritoneal disease, their life clock is actually start ticking. So then after that, we cannot wait too long. So normally we give around a month, and that's about it. So to answer your question, is there a cut-off limit? Of course, we're not going to do CRS HIPAC someone who is like 90 years. But with that, we have a cohort that we have done quite a few patient is 78 or 70 to 78. So they are doing okay.
Yeah, I think it's more about biological age rather than chronological age, because you can have really unfit 60-year-olds, and you can have a reasonably fit 80-year-old. So I think that's why we don't specifically go by chronological age. You also kind of have to look at the family, are they a family with great longevity? If everybody is surviving to 100 plus, then maybe a 90-year-old is not really beyond the realms of possibility if they are biologically fit. So that's the answer to that. And that's why the MDT is important, and sometimes in our MDTs, we will have cardiologists, pulmonologists, and so on, because we really want to get a really complete picture of the patient's status. So while we're waiting for some more questions, maybe for our audience, if you reflect on this case, is there anything that you would change about the management, whether it's in terms of the actual interventions or the timing or anything like that?
Are you asking me, is it?
Yes, I'm asking. Would you change anything about this patient's management?
Right. Yeah. So for me, I would one is one, the management is, I know one is disease patient is young, and second, I cannot rely on the tumor biology, and I know I cannot rely on the tumor markers because the tumor markers is normal, and then every time it's normal, and then I would say, okay, and patient has a peritoneal nodules, and at the time was very small, so whether I would want to know these peritoneal nodules, whether is this a metastasis or not. So the other thing, if I would want to change is, I would do a laparoscopy surgery and then see whether is there a peritoneal nodules that I can take it out and send it off and to confirm sooner. So that's one. And then having said that, and this patient had two operation, and when we did the laparoscopy, surgery and is dense adhesions. So so the other thing, which is I often mention that to this patient, we may convert to laparotomy because we really need to actually get the peritoneal disease. And then the other thing is we really need to know where is actually this peritoneal disease is. Because can we remove all or not? And then we have to inform the patient how much multivisceral that we're going to do for this patient. Yeah. So that's I would say I would do differently, and the other thing is probably try to convince her on the tumor biology, and then that's about it actually.
Yeah, I think for, especially for the trainees in the audience, I think it's important to understand the pitfalls of our usual surveillance methods. So the index of suspicion is really important. And in this case, the patient has quite a few red flags, right? Young patient, somewhat emergent presentation, right? Normal CEA at presentation. So when somebody has a normal CEA, you cannot use it, for surveillance on its own. Okay, so to me, I think I would probably have intervened earlier at 2020 when the pelvic nodule was present because it was visible. I think there wasn't even a PET CT done at that time,
Correct.
laparoscopy. So maybe you could
Yeah.
have.
True. True. If you talk about the imaging modalities at the present time in the surgical in the peritoneal disease international, they talk about the MRI, and that is patient who has a multiple operation, whether they can detect that. That's one. Secondly, they talk about FAPI, FAPI PET scan. So this is actually, it is a new thing on the block, but we don't have that modality at the moment. I'm sure we will have in the future. But these are the things that we probably could do as an adjunct on this patient.
The other things, the other red flags is obviously her histology from the first surgery, right? So you've got someone who's N2A, right? It's moderate to poorly differentiated. These are all biological
Yes,
anomalies.
correct. Correct.
So the point I'm trying to make here is that this patient has a lot of red flags, and therefore the surveillance methods might not work for her. So maybe we should have done some other things earlier on. It may or may not have changed the outcome, but perhaps your PCI score would have been different if you had gone in a bit earlier. And I think that's important also, right? The PCI score determines in part
Yes,
as
correct.
will be. So for you mentioned that patients are homogeneous, but actually you only mean homogeneous in terms of they have to fulfill the selection criteria. Actually, patients are quite heterogeneous, right? In terms of PCI, in terms of their histology, because we're just talking about colorectal cancer here. Whereas HIPEC is done for other things as well. So tell me a little bit about the PCI, because you said it was 15, right? And in colorectal cancer, is 15 like great?
Yeah. Okay. So just for the audience, so PCI score is actually a prognostic factor. Basically, the for peritoneal disease, whose patient who has peritoneal disease. So basically, we want to, if they have a lot of peritoneal nodules, their PCI score going to be a lot. A lot means the highest is 39. Can we do patient with 39? We may or may not. The other thing, can we get the clearance? We might not. You get what I mean? And then because the higher the peritoneal nodules means like the higher morbidities would be. So the question is, at what cut-off point that we actually say, okay, this is the maximum that we are going to do, more than that we're not going to do. Or it's not that we're not going to do entirely. So probably we can use the chemotherapy as a new adjuvant first. So for colorectal, we take it as a 15. But there are centers in America, and they take it as a 20. So when we went for meetings internationally, so I did ask, so it's like, why there is a 115, and then some of them are 8, and then 20. So they say as long as we can remove all with the CC0, means like no cancer that we can see, we go ahead. So but provided you also don't want that this patient has a high morbidity, then longer in the operation for recovery. Then after that, while recovering, patient develop peritoneal disease again. So so we want the patient to quick in and quick out, reasonably quick out, and then having their bidirectional therapy. So for colorectal, in this center, we think that I'm comfortably I've done up to 19, but actually it's long hours operation, but I take it as a 15. For gastric, is literature shows is 7. And then for others disease, some of them is 39, we still do it. That is different kind of tumor biology. So here we are actually focused on the colorectal, is 15.
Yeah, so just for the audience, different histology, the limits are different, right? So for colorectal cancer, for instance, it's lower than, say, for your what was it? Your peritoneal disease, your primary peritoneal diseases. And then gastric cancer obviously is much lower. So what you're looking at is whether you can give any benefit to the patient, either in terms of reduction of symptoms or disease-free survival or overall survival. So if it's beyond that, the morbidity of the surgery is not worth it. So maybe, Rezal, you didn't actually highlight, how long the operations are, like
Right.
long, and then how long do they stay in ICU, how long do they stay in hospital, the cost as well.
Yeah. So right. So for this patient after they woke up, right? Of course, when I always invite the patient come in to the clinic firsthand with family members, and then sometimes I do have to make an arrangement for them to come to another day, not at a normal common clinic day, because the consultation is extensive and it has to be repetitive. So we have an allocated medical trainees, doctors to actually help with me on this portfolio. That's one. Secondly is the operation, the more tumor burden, the longer the operation is. So yes, we have done patient, I think, not to scare you, from the very earlier cohort, and then we'll talk about some of them is up to midnight, and then if you want to talk about hours, can be 24 hours. Sometimes we have to break it into 2 days. You got what I mean? It's not just us. Centers, when I was working in Singapore, so they break up into 2 days, and then where we call it stage CRS, and then but after a while, after we've all been trained, it's getting better and better and better. So now it's a 10 hours operation. So that's on the hour side. So all these patients will have to be in the ICU for about 2 to 3 days. And then this is where we're going to optimize these patients, their temperature, and then their acidosis, blood loss, and all this kind of thing. They have to be attended by the intensivist, and we have to be in communication with intensivists all the time within these 3 days. So you can see that the effort here is not just myself, it's a whole team are busy and then to take care of this patient. So hence after that they will be in the ward. Where they in the ward, I always ask the patient make a promise to me that they will do their rehabilitation right. So we have to teach them even before the surgery, and then how to do the intensive spirometer, and then how to walk, how to stand up. So it's a lot of effort on this patient. That's one. And then so that's length of stay. How long they stay depends. So if they are fit and then tumor burden is less, so we have patients like within a week they actually done. So there are patients who stay with us. Generally, we'll talk about 15 days. But in the hospital, we try to be to cut down, and it's possible. But all this literally after the surgery is a patient effort that they have to do the intensive spirometry. You can see the amount of drains that they have in the abdomen, and then sometimes in the chest we have to put chest tube, so things like that. So that sometimes limits what they move. So that's that. And then the other thing is cost. Okay, cost at the moment is for now patient has to pay 10,000 ringgit, which is 9,999, and then that is for the canister. And the function is called canister is where the chemotherapy that we're going to put inside, and then after that it cannot be recycled and it's only for patient only. So that's one, but they still have to buy other things, like for example for anesthesia they have to buy the flow tracks, which is around 2,000, the pain comforter, which is around 1,000 plus. So all that will add up around 15,000. So that's that. But having said that, they can claim from the insurance, they can claim from the GL, because this is a curative intent. So this is not a palliative intent. So they can claim that.
Yeah, so I think those costs you're talking about are just the consumables. It doesn't
Right.
all the other things. So I mean, easily the actual true cost is somewhere in the region of 50,000, and in private it'll be even more than that. If you consider the long hours of surgery and so on. So basically the good outcomes that Rezal has talked about is because the patients are highly selected to be the ones that can benefit. So if you notice earlier on, Rezal mentioned that out of 162 referrals, we only proceeded with 47. So it's a highly selected group. It's not just try, right? Because there's so much work that has to go into it, and at the end of the day, patient has to benefit. Now we have one last question from the audience. The question is about research gaps. So what do you think are the future directions for research for CRS HIPEC? You mentioned prophylaxis, so yeah, we're not going to do prophylaxis. What else?
Exactly. So the randomized control trial, things like that is going to be hard here. One is like we only do 1/3. We can see that out of at the moment, at the present time, we have 262 referrals and we have done 79. It's literally at 1/3. So it's very difficult to randomize it. And then that's one. And then so the research gap
what are
here.
The directions? What are the directions?
Yeah. So other things is I would say the tumor biology, and then that was something that I would love to look at it. And then the other thing is because our center is a heterogeneous, so it's not just colorectal, so it's other things, it's appendix, gynae, primary, so they have different tumor biology. They have different kind of tumor profiling. So this is what I would love to look at it on that.
And what about internationally? Because I mean, research
internationally, yes, collaborate. Of course, our neighbor country, Singapore, as that would be that would be good to collaborate with them, because they have.
What I mean is, you've been attending all these conferences. You've networked with people. Where are the top centers in the world heading towards in terms of research? What are the questions that they're trying to answer?
Okay, so basically, okay, what they're trying to achieve on this research, they're talking about organoids, they're talking about many things, but at gist is like what they're talking about is how how aggressive is this peritoneal disease and how can they attack it. So they are looking at, is there a benefit with immunotherapy after that? Is there a benefit with targeted therapy? So these are the things that they're looking at. Yeah.
So if I can encapsulate that for Gauri, who has the question, is basically about how can we be more precise about treatment, right? So whether it's from a molecular basis or therapeutic basis, how can we better select or better treat even the more aggressive conditions from a molecular basis? All right, so that brings us up to 8:58. I think we've had a good discussion. Thank you to Dr. Rezal for presenting, his experience in this area. It's not for the faint-hearted, but I think with good training, good teamwork, you can see so many people, so many teams are involved in this. We can actually provide benefit for a significant number of patients in terms of either their improved quality of life or their survival, or both. So I hope that everyone has learned something from this morning's session. And if you do come across possible or potential patients for CRS HIPEC, do send them along to us. With that, thank you very much, everyone. Don't forget to fill in your attendance forms for the CME points. And we'll see you again next time. Thank you.
Thank you.